Mr. McLean, one of your recommendations is to review all personal evaluation metrics and ensure that all VHA employees, from clerk to clinician to senior managers, are evaluated based on outcomes for veterans who are seeking and receiving care from VHA. Mr. Michaud, you also urge the VA to support outcome focus on leadership. My question to you two is, the over-reliance on metrics has been mentioned as one of the factors leading to the current wait time problems. How do you distinguish between metrics and outcomes? Mr. McLean?
Thank you, Mr. Michaud. My short answer to that would be that most of the metrics that are reported today in VHA, and there are hundreds of them, are process-oriented. And simply checking a box or doing something versus actually measuring what that accomplishes or the outcome. And so my point in making that was that we should be rewarding and measuring outcomes for veterans, good health outcomes, rather than simply checking the box and doing a process.
I would add that it's just the sheer size of the numbers of metrics. If you went the HR route and pulled a middle manager's evaluation within the VA today, you would see metrics scored by the dozens. Mm-hmm. And if you think about that many metrics, how can a leader give any proper attention and proper priority when you have a weighted evaluation around those that are outcomes versus process? You have the ability to create focus and priority, and that's what I would say is not just the metrics, but the sheer number of metrics that we're looking at.
Thank you. Is it valid to have a strategic metric, then, Mr. McLean?
I think that it's valid to have a strategic goal as to what the outcomes might be and be measured against that goal. I think that's valid.
Mr. McCullough.
Look over on the.
Yes, I wanted to point out.
Mr. McCullough, would you answer?
Yeah, if you look, go to the CMS website, and you'll see one of the metrics that the private sector is really paying a lot of attention to right now is readmissions. We know the fact that a tactic like a post-hospitalization phone call has the ability to reduce readmissions. And yet what we don't do is we don't measure hospital operators on the number of post-visit phone calls that they make, because on the publicly reportable websites that you would find the actual readmission rates for folks within certain disease categories.
Okay, thank you. Some within the VA has raised concern that there are inadequate numbers of extenders, and this causes physicians to spend undue time with paperwork and routine clinical work. Ms. McLean, what does the private sector use as a benchmark for the physicians to physician extender ratio?
It varies depending on what type of clinic. Our involvement are with the community-based outpatient clinics. We operate 34 of those under contract with the VA, and so we have we utilize VAs for the most part panel size of 1,200 per physician, and then the support, the medical and also administrative support for a single doctor would be somewhere near 4 or 5 support personnel for that doctor.
Mr. McCullough?
I would defer to Mr. McLean.
Okay, thank you. Doctor, on my question for you would be, I'm interested in your comments on the VA paying for care for patients already covered by Medicare Advantage and the potential for the government paying for care twice. What policy changes could remedy this situation?
Well, it's very interesting that such a large percentage of vets actually have insurance. Only about 10% of vets being treated at the VA are, quote, uninsured, and it's probably tragic that they weren't included in the Affordable Care Act. But nevertheless, many of these vets who are insured, either with employer-based insurance or Medicare Advantage or regular Medicare or Medicaid, resist going outside of the VA system because of the out-of-pocket expenses. And as I explained before, if we gave them a Medigap card for the seniors, particularly a Medigap card, a special VA Medigap card that absorbed those out-of-pocket expenses, they could seek a lot of care in civilian hospitals, particularly teaching hospitals, that are high volume for angioplasty, bypass surgery, hips and knees, some of the things that seniors frequently need. So they'd be getting, in many cases, better outcomes, not always better, but often better, and it's budget neutral for us as a nation. It's budget neutral.
Thank you. And incidentally, under the Affordable Care Act, 3,000 Mainers were denied access because our governor refused to expend Medicaid to the 70,000 Mainers, of which 3,000 were veterans. So thank you. Thank you, Mr. Chairman.
Thank you. Mr. Bilirakis, you're recognized.